Hey Nav, this is Rachel.
Hey, can you hear me?
Yep, I'm gonna
Perfect.
try to launch a quiz question well, I have a couple quiz questions that are just like basic stuff. So tell me if you can see them. I think I just would share my screen and that would be what I need to do. Eh.
Hold on one second. I'm just trying to figure out the sound settings here. All right,
Can
can you see?
anyone see the quiz question?
Yeah, I can see it.
Uh,
Yeah.
Well, hopefully, then I'll stop right now.
Let me get
I
this
stop sharing.
loaded.
I would recommend that you give a brief history, but not what your suspected diagnosis is, because that's kind of the quiz questions. So,
Uh,
or whoever's giving the history, that it's just kind of like
yeah,
the.
I'll do it. I'm just reading through what I have here. Yeah, it's pretty here, let me if I that's fine. Yeah. I have like a slide that shows kind of like when we prescribed
Yeah,
certain
I mean that's
things.
fine. Yes, I mean they need to know the clinical to get an idea of like what's
Sure.
going on. So if we're thinking of like them as being clinicians, they would know the clinical background. So,
Yeah.
but just don't
Okay.
be like, and then we found a blah 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 in the glomeruli.
Yeah, no, I'll leave all that stuff to you. Let me just see if this works because the screen sharing is giving me a weird privacy settings. I have to leave the meeting and rejoin it. Give me 1 second.
Okay.
All right, I can try to share it. I don't have a share screen option. There it is.
Yep, I see it. Oh, Dobby.
Can you
Yep.
see the whole thing now?
Yep.
Okay.
Okay, people are still continuing to join. Um, uh, and we are recording. Um, a few housekeeping things that we always do before every meeting. If you have a case that you are interested in discussing and presenting, you are please let me know as soon as you get the idea that it would be a good case to discuss. And it doesn't have to be a formal PowerPoint. Nav was nice enough to do this. I actually asked him to discuss this case because I thought it's a cool lesion. So it does not have to be professional. It could literally just be what you remember about the clinical. Because for those of you who've attended here, you know that most of the conversation is about the pathology itself. And it doesn't have to be as professional as taking the time to make all the PowerPoint information. Don't be intimidated by that. Um,
We don't like professionalism.
Thank you, Dr. Hokamp. I just don't want anybody to like chicken out from not recommending a case just because they think it's going to be extra work. Like it doesn't need to be any extra work unless I say, "Hey, do this." I'm joking. Um, these are all stored in a repository, and I think they're actually even making us our own kind of blurb page on the ACVNU that describes the rounds and then provides the links so that they will be a little bit easier to search. I think that's in the works. But the last point for housekeeping is that if you get kicked off the list or you know of somebody else who has accidentally been kicked off of the distribution list and they have not received an invite in the past, month or so, please send me an email, send Dr. Hokamp an email, Dr. Nabity, any one of us at the IVRPS, and we will make sure that the distribution list gets revised and your name gets added. As people leave pathology, or sorry, as people leave different residency programs or different jobs and their emails change, I get pretty good at getting that updated. You guys are pretty good at emailing me to say, "Hey, I'm at a different email address now," and I try my best to do it as soon as you email me. Um, so that you're up to date. And then as soon as I get a rejection from the next invite, I delete the old address. Please just be conscious of the fact that sometimes Outlook decides to delete things that I did not myself delete. Any questions or comments or feedback? I think if you look back at the very top of the chat, there are a few poll questions. I think they'll probably be relevant maybe in the middle of the meeting. And so if you want to go to the poll EV address at the top of the chat and click on that, it should allow you uh, to see the questions whenever I launch them, although we've only done it a couple of times and sometimes since it takes about a month for us to figure out how to do it again, sometimes we forget. So please be patient with us for that.
Rachel,
But
can you
yep,
resend it one more time? Because anybody that's new that comes on, it doesn't show
yep,
the beginning part.
yep. So I guess, yes, if you joined, you can't scroll to the top of the poll. So, but that is the website for answering questions whenever they get asked. Okay, Nav, do you want to talk about Dobby?
Yeah, sure. So Rachel asked me to present this case, which is one that we biopsied recently. Unfortunately, the dog is coming in for a recheck today in about an hour, so I don't have updated information, but I can kind of talk about Dobby. So this is not an exhaustive PowerPoint. I just thought it would be easier to kind of show the timeline of the presentation. So Dobby is a 4.5-year-old intact male Cavalier King Charles, although I think he's more of a mixed breed dog that presented to me in April. He initially went to his vet in mid-March. He had a suspected seizure. The owner witnessed him paddling and had some salivation and sounded pretty much like a seizure based on the description that was written in the medical record. At that time, he was diagnosed with proteinuria, and he also had a progressive mixed hepatopathy on lab work and a hypercholesterolemia. When he saw us at AMC, that was about a month later in April, and he was referred for workup of the proteinuria. He had no further seizure activity, and he was not put on any anti-epileptic drugs by his primary care vet at the time. When he came in to see us, initially, I can't remember, he didn't have a UPC done back in March. He just had proteinuria on the UA. And at the time, we were not sure if the proteinuria could have been associated with the seizure. So we repeated diagnostics at AMC, and his UPC was 3.2. He had a urine cystatin B of 79. Blood pressure was 155, but he was a bit stressed in the hospital. And his albumin was 3.9. He was non-azotemic. His creatinine was 0.6. And he had a even more progressive hepatopathy at that point with an ALP of 2100, about a hypertriglyceridemia of 879, the hypercholesterolemia of 1136. And on ultrasound, he had a hypercoic hepatomegaly with some gallbladder cystic mucinous hyperplasia and BPH. About a week later, we submitted an SDS page and a urine cortisol creatinine ratio, which was done to screen for Cushing's. That was normal. And the SDS page we submitted, and then there was some scheduling delays between the SDS page and the renal biopsy, which was done a couple of months later. And so this is kind of just some snapshots of the lab work that we had. So I didn't have his blood work on hand to kind of put in from the March visit. But when he first saw me for the initial consult in April, his ALP had jumped up to about 2,000. I believe it was in the thousands in March. And his cholesterol and triglycerides were also higher. And looking back at history for this dog, it had been progressively elevating both the triglycerides, cholesterol, and also the ALP actually over the past year or so. So we started ursodiol at that initial consult based on the ultrasound findings. And then in May, we started the dog on a low-fat diet and fish oil and telmisartan. And a lot of the timeline here was due to kind of back and forth communication and owner traveling and not comfortable starting medications while he was away. And then I guess I'll let Rachel kind of talk about the renal biopsy, but the SDS page that we submitted was consistent with mild glomerular dysfunction. And at this point is when we had recommended starting the telmisartan. So his lane is obviously outlined here. And so there was no evidence of tubular disease, no bands over 200 kilodaltons, and just some evidence of mild glomerular dysfunction on the SDS page.
Cool. Okay. So is it okay if I do the pathology now?
Yeah.
Okay. And we're gonna watch you eat unless you're gonna turn your camera off.
No, I'm gonna turn off my camera for that part.
I just saw that and I was like, you might dribble some food out of your face. Okay. Let's see.
That's what the beard's for, Rachel.
I need to share my correct screen. Let's see. Okay, so we got the biopsy in June, and you should probably gonna be seeing my Teams page for just a moment. And so as you guys know, we have histopath. We do that usually first, and then we'll get some immunofluorescence kind of around the same time. And then we will get the electron microscopy maybe a couple of days, maybe about a week later. Are you guys seeing a core of tissue?
Yep.
Cool.
We've got your little
Box there.
Yeah, there you go.
So the pathology stains that we do routinely are an H&E, a PAS, a trichrome, and a silver stain. I think the silver stain is not going to look that great because we were kind of going through a change of a kit, but so if the silver stain isn't amazing, then please forgive us. Actually, this was a case in which the team at Texas A&M, they get the slides from the lab. And they quickly scan them or not scan them, they look at them themselves to make sure it looks like a pretty good section and a pretty good core before they submit it to the GI lab that scans the slides. And so we actually review the slides on the GI lab server. And so this one actually they flagged as being a little abnormal. And so their question was, what is going on with these glomeruli and why do they look like Swiss cheese? So we have a really good 2 set of cores. We've got both cores are entirely cortex. And we had a sufficient number of glomeruli for evaluation. And even at this 3x we're looking at, you can start to see these clear spaces that are hanging out within the glomerular tufts. And they are kind of widespread throughout both cores and within multiple different glomeruli. And so as we go to higher magnification, we can see they're quite discrete. And they sometimes are single within a glomerulus, sometimes they are multiple within a glomerulus. Like this particular one maybe has a little clear space, maybe a very small one, but then other glomeruli have much larger ones and they have multiple per tuft. And not every single tuft has one. Here's probably an edge of a tuft that doesn't have that clear space, but many do. And so the repeatability The similarity in these appearances made us suspicious for a very specific process. I'm going to show you what it looks like on the other stains, and I'm going to quiz you about what it is. So, so your next question is, well, does it stain with anything? We know it's not staining, or it appears to be clear on the hematoxylin and eosin, but what does it look like on other stains? And so with the PAS, we can see once again, it's this clear, clear space that's quite encircled by the PS positive, probably GBM material, maybe even some mesangial material. The trichrome as well shows, again, the clear spaces. So it's not staining with any of the labels that, or any of the material we would think that trichrome would stain. So it's not staining cytoplasm. It's not staining like as if it were collagen. Collagen would be blue, and it's not blue. And sometimes you can see these little things, which are probably red blood cells that are kind of squished to the side. And let's see, I don't remember what the Jones looks like. It's not that great of a day for Jones. I mean, it isn't so bad. So you can see the Jones is showing glomerular basement membrane material. It shows it quite black. It shows mesangial material black. So what I'm actually drawing my arrow around right here is mesangium. Here is capillary wall. And you can see, again, this material does not stain. So let's see if I can launch a quiz question. Let me stop sharing this. Hopefully, let's see if I can get my thing up and running. You guys can I'll put the link one more time for anybody who just joined. Now I have to remember how to do this, sorry. Okay, I'm gonna present it. Oh, and then I need to share that screen. Let's see if this works. Okay, you should be seeing a screen. And if you go to that link or a QR code, you might be able to get to a site that gives you these options, and you can click. Okay, we at least have one response. That's good. That's good. That's a good start. See if we can get a few more responses. We're obviously not going to take too much time because we have a lot of things we need to do today. I'm going to go off camera so I can blow my nose. 1 second.
Sorry, Rach, it's being funny for me, so I don't know if other people are having some issues getting it to work.
Okay, well, we have some answers. Okay, let's see. So let's see what the responses show. Okay, so we have most people saying it's lipid. We have one person's or an answer for plasma. And this is lipid. So it's not staining because when you do the tissue processing, so it's not staining for anything. It's not staining on any of the special stains that we used or the hematoxylin or eosin. And the reason behind that is that when you process the tissue, so that means it's already formalin fixed, it goes through a tissue processor before it gets embedded into paraffin. That processing does a whole bunch of serial dilutions or incubations or whatever you want to say with alcohol, and it takes out the lipid. So the lipid washes out of a processed sample. And it is no longer present so that by the time the tissue is embedded in paraffin, the lipid has been dissolved away. Does that make sense to everybody? So it won't stain with anything if you have a processed piece of tissue. And that's why when we think about lipidosis in hepatocytes, again, it's quite clear space. It's quite discrete. And if you wanted to prove that there was lipid in any kind of cell type, no matter what you're looking at, you can't use processed tissue. You can use formalin fixed tissue, but you can't use processed tissue. So you have to do a different type of preparation in order to maintain the lipid within the tissue and then getting into the paraffin block so that you can then stain it later. That's always one of these things where it's really difficult for these this material to be observed. Okay. So let me go back really quick. Are any questions about that? Oh, yeah, sorry. I needed to set it up. I apologize. That's my problem. I needed to set it up so that I said you guys don't have to log in. That's my problem. I apologize. If you already have a poll everywhere, it would have made you log into your account. But that's my problem. I'll just remember the next time I do this, in whenever I decide to make quiz questions again, I'll set the questions so that you guys don't have to log in, and you can answer them anonymously. Okay, that's my fault. Okay, let's see. Okay, so you guys saw all the clear spaces. And okay. Oh, actually, I can do the next question, I think. Oh, okay. So no, I didn't have that next. So I thought I'd ask one more question, but I didn't. Okay, so this diagnosis that we use for this lesion is called glomerular lipid emboli. I actually think in the paper I used the term thromboemboli, and I probably shouldn't have. I probably should have just said emboli. I wasn't sure at the time. We still aren't sure whether the lipid droplets kind of polymerize together within the capillary loop. So more of thinking like of how a thrombus might form inside a capillary loop where it's done in situ, or whether the lipid is formed somewhere else and as a big polymer, as a big globule, maybe that's the best word for it, and then circulating in through the glomerular capillary loops. And so we're seeing it in circulation. And I think it's possible that both are happening. I don't know still. But I think because I use the word thrombo in the paper, it kind of almost suggest that the coagulation cascade is actually truly being activated, and I probably shouldn't have used that term in the paper. So now I just pull Linden Craig and rechange my original publication, and I say now it's just glomerular emboli. And so I can just do it because it's our paper. So, but we don't really know, like, does it make a globule of fat within the capillary lumens? Because it's not like we see these globule of fat everywhere else in the dog if we were to look at multiple tissues. So is that globule like forming within the glomerular capillary lumens, or is it something that's always in circulation and we just happen to be able to catch it when it's going through the glomerular tuft? And so we're not sure. Okay, so then so there's a certain breed that is predisposed. And I'm gonna ask you that question if you guys want to log in and see if you can answer this question. Hold on, zoom. Share screen. Okay, and it should be able to see it even for those of you who can't don't want to log in. At least you can mentally answer the question. Okay, we've already got about 9 answers, 10 answers. So what breed is predisposed? Miniature schnauzers. Okay, cool. So I think Labradors is always good because Labradors do everything. So miniature schnauzers seem to do this lesion a lot. And so it's probably because they have an inherent dyslipidemia, hyperlipidemia in that breed anyway, so they're more likely to be able to make these lipid droplets. And then kind of my my backstory to kind of, you know, the rule, or not the rule, I guess I say the background that kind of proves this. Anecdotal evidence, that's the word I'm looking for, is that we had one case where it was way back when I was still at Ohio State, probably had just started there, and we were just getting the biopsy service up and running, and we had 2 biopsies come in one day, which was just amazing to us, although now that's fairly routine for us to get 2 biopsies in one day. And so I looked at it, I saw the exact same lipid droplets, and I was reading the history, and it was a German Shepherd. And I was like, well, that's strange. And the next case I had some other disease, but that was a miniature schnauzer. And I was like, So I went to the lab and I was like, I don't want to like throw anybody under the bus, but is it possible these samples got switched? And because we're really good in the lab about annotating the size of the samples, how many come in, what they look like, we were able to verify that actually the slide that I was looking at was mislabeled, and I was looking at a lipid case from a schnauzer. So I was able really quickly to say, yep, he had 2 cores. It has to be this case. It must be that the slide was mislabeled. We went back and traced it. We even resectioned the blocks, and everything was verified that the miniature schnauzer was the one that had lipid in it and not the German Shepherd. Now, this is not a miniature schnauzer. This is Cavalier King Charles. And we occasionally see this lesion in non-schnauzer breeds. And I don't think I've ever seen it in a standard channels. Or actually, could the clinicians in this call comment on whether standard schnauzers ever have the hyperlipidemia? If you guys can put in the chat or speak up. I don't think they do, right? It's just a miniature schnauzer version. Okay, well, I'm gonna keep talking as people put that in there. Okay. So you see a lot of standard schnauzers, Shropshire? Okay, interesting. Um, so um, so uh, so we think that yes, it is a miniature schnauzer thing, and we have seen it in other breeds. And then usually when we go back and ask them about the lipid profile and the cholesterol profile, they have very, very high triglycerides and or cholesterol levels. And so it makes sense that that makes a globule within the glomerular tuft. Oh, interesting. Okay. Let's see, what's my next question? And then I will show you some information about the other portions of the study. What's my next question? Oh, I know what it is. Okay, I'm going to ask you one more question, one more pathology question, and then I'm going to go back to the pathology itself. Okay. Okay, so one more question has been launched. And so what is the significance of the lipid within the capillary lumens? So we have the options of is it possible that it injures podocytes? Does it incite immune complex deposition? Does it cause glomerular crescents? And so remember, crescents are accumulations of cells within Bowman space. Usually they are due to ruptured glomerular capillary loops or ruptured Bowman's capsule. So a lot of times it's inflammatory cells and a lot of matrix. And then the last option is it does not cause any glomerular pathology to our knowledge. Okay, let's see what the responses are. Are you guys seeing the responses? You're seeing the screen, right?
Yeah, we're seeing the percentages. Yeah.
Okay, good. Because I think when I do these and I try to do it on Zoom as a word cloud, I think it's difficult to show you guys the word cloud, but I think you guys at least can see the answers for this. Okay, so we have some options. So we have the majority saying that it stretches podocytes, stretches the glomerular capillary loops, and it injures podocytes, which is our proposed theory of how it enters glomeruli. And so we do not see this lesion associated with immune complexes. We do not see it associated with glomerular crescents. And it's very possible that there are some dogs that have these globules in circulation and they haven't yet had any glomerular pathology develop. So there could be the possibility that sometimes they will have normal glomeruli on histology. But I think that could just be that we haven't had that particular dog hasn't had enough time to have the capillary stretching and the podocyte stretching, and that eventually it probably would. So if we go back to the pathology for this,
Rachel, you're only looking at dogs who have proteinuria for the most part that
correct.
mean that something has injured some aspect of glomerular permeability. So
Yeah, I agree, and I think that's
there are the dogs walking around that have small emboli that don't cause any pathology that you never see.
I agree. I agree. So we don't there, and I will say the paper where we talk about this lesion specifically in miniature schnauzers, that paper actually was written about what do we see in miniature schnauzers. And so it wasn't specifically about describing this lesion, although it said we saw this lesion in a large proportion of them. And so there are times where we'll see a miniature schnauzer breed and they will be proteinuric because then that's why they got biopsied, but they have a different type of glomerular lesion. And often those miniature schnauzers are more likely to have podocyte injury, so focal segmental glomerulosclerosis. And so they might have FSGS, but they don't have any of these circular lipid droplets in their glomerular tuft. So this particular case actually doesn't look like the glomeruli themselves don't look very scarred. Like we had one glomerulus that was globally scarred, but most of the glomerular tufts only have the lipid droplets and don't have significant sclerosis on histology. And so again, this is probably an early stage lesion. And we would expect at some time that the podocytes, as they are stretched and injured, they are eventually going to detach and fall off into the urinary space. And eventually, the glomerulus would start to have sclerosis, which is basically scar tissue in the glomerulus. We might have a little bit of podocyte injury here because we have a small synechia. But again, it's very, very mild on histology. With Nov's comment that the dog had kind of had creeping up uh, uh, triglycerides and cholesterol, and I think you said Navi's like 4 years old. So, and you know, how often do we get all the blood work from those dogs like that? I mean, that's amazing. You already had blood work from a 4-year-old dog. Usually, people don't do anything until they're like the 7-year-old just to get the baseline before when they become geriatric. You have some information that this is going to be a chronically progressive process. And then also they've already started to somewhat intervene by feeding a fish oil diet. So again, this will be a really interesting case to follow to see what's going to happen with this particular dog. One final comment before we leave histology is that part of my theory of why the globules might start to accumulate within glomerular capillary loops, and maybe they started as small but they keep getting lodged and stuck into capillary loops, and so they get more and more lipid kind of going there and forming. I mean, lipid's just hydrophobic, so could just merge to another droplet. Is that you're not seeing a lot of droplets in the peritubular capillaries. So it might be something about the glomerular loop that makes it more likely to have these lipid droplets, as opposed to in the interstitium, you're not seeing that same kind of lipid accumulation or droplet accumulation within that region. So I think there is something about the glomerular capillary loop that's allowing this to happen. Okay,
I
I
was
do
just
need to.
looking back and just for tracking values. So in 2024, the cholesterol was about 595. Then it creeped up to like 700 and 800 over the course of the year. And the same thing with the ALP. It kind of gradually creeped up. It was 781 about a year ago. And then when I first saw the dog, it was about 1700. And then when I rechecked the dog, it was in the 2000s. So I assume there's some vacuolar change occurring in the liver as well.
Yeah, that makes sense. Do
And
you?
the other thing to remember about the peritubular capillary is that all the blood running through those has already been through glomeruli,
Yep,
pretty
that's true.
much. So, you know, they've been sieved out maybe before they get there.
That's very true. So so if anything was gonna go and get um blebbed onto the globoid droplet, it's gonna do that as it's going through the capillary, the glomerular capillary, and so then the stuff that would come out of the efferent vessel, which should be relatively low on lipids because everything's kind of going there.
Let me also comment too. The glomerular capillaries are not like peritubular capillaries or capillaries elsewhere. They're fenestrated. You know, they've got all these properties that are special to being a glomerulus. And the other thing, and it may well be just plain physical size, distension of the capillary, stretching of podocytes, and the consequences of that. But lipids also carry stuff around, some of which is obnoxious when it gets where it's not supposed to be. And I don't know what that would be. There's certainly not much sign of inflammation to go with this, but it could be damaging to the endothelium as well as to the podocytes.
I mean, I guess one
Yes, I
other
agree.
question: if the dog's not hypoalbuminemic at all, is it possible that the lipid droplets contain proteins, chylomicrons, et cetera, that are going with it, and that's the protein that we're seeing on the UPC and the SDS page? Like, do you think it's out? I have to go back and look actually at the SDS page to see how
That
thick
sounds like
that
a
albumin
HOCAM
band
question.
was, but I don't know if you can kind of tell if some of those lipid-associated proteins might be a component of the proteinuria in this dog?
I have not seen anything specific with these lipid emboli dogs that makes me, makes them jump out to me, other than the fact that like specific breeds. And I always wonder about it with specific breeds, but I have not further explored that with either mass spec or delving into additional separation of the high molecular weight proteins that we see. But again, they kind of just, in most of the cases that I've had with these glomerular lipid emboli, they're similar to Dobby's, where it's a sort of mild to moderate pattern with nothing specific that leads me towards one diagnosis or another.
Yeah, it really fits more towards just leakage of mostly albumin and a few other things from glomerular damage.
Yeah. Similar to what we see with like an FSGS.
And so I'm showing you an image of the electron microscopy, and I did first and foremost, the glomerulus that was available for ultrastructural evaluation did not have one of those globules in it. And depending on time, I'll either ask you a quiz question about it, or I will show you what it looks like in other dogs. And what also, just so you guys that are clinicians know, and we just did this little workaround today for a completely different case, completely different diagnosis, is that when we're deciding which glomerulus, or when we're looking for a glomerulus in the sample that is set aside for EM, so it has gone into, it comes from you guys or the clinicians, it goes into the lab changes it from formalin into glutaraldehyde, and once it's in glutaraldehyde, that's when it gets processed for electron microscopy. And it gets put into an EPON block. And if any, let me know, you guys put in the chat if you want to see what a picture of an EPON block is, because we actually just took one. So it's this tiny little EPON block, and then you cut it at like 1 micron thickness. And you have to say, is there even a glomerulus here? Is it worth putting this particular piece of tissue onto a copper grid, because am I even near an area where a glomerulus is? And when you're at that step of EM processing, you put it, the 1 micron sections, you put them on a glass slide and you stain them with a very quick toluene blue. Again, it's not the same way we would do like a mast cell tumor, because there's no counter staining like that. It's just a very quick droplet, and it will show you that like where are the tubules and where's the glomeruli. And so you might cut through different regions, and Amy does this a lot. I'm not sure if Amy's on the call, and there might be like, you check like 5 different times and there's no glomeruli. So you don't want to waste a copper grid for that. And so instead, once you find the glomerulus and like I'm not just at the edge of it, I'm actually within the glomerular tuft proper, then you feel confident that that particular specimen is going to be good for electron microscopy evaluation. So then it goes to the copper grid, and then it gets stained so that it has this black and white appearance. The glomerulus that was available for EM did not have one of those droplets. And now, to be clear, it could have had a droplet deeper in the glomerulus, and that we're looking at such a thin section, it's just an area that didn't have a lipid droplet. So it very well could be that if we section deeper into this glomerulus, we might find one of the lipid droplets. What we do find in this glomerulus is that there is mild foot process effacement. So let's see. I'm going to try to draw on this just so you guys can see what I'm talking about. This is the actual, oh no, I'm on Zoom, so it's fine. So here we have foot process effacement, okay? We probably have a little bit here, but it's not bad. Oh, that one's not letting you draw there. But we still have pretty good, or we have visible foot processes in other areas. That one circle did not decide to stay up, but we at least have areas where there is foot process effacement. So we know the podocytes are not 100% normal. And then, oh, what's happening now? Hold on. Go back to home. Oh, it got mad at me. HoCamp, I messed it up. Hold on. I'm going to stop sharing. 1 second. I can fix this. Oh, I know what it's doing. It's trying to make me do a different.
In the meantime, I put a picture of an EPON block and the T-blue in the chat just for funsies.
I think what happened it was oh, it's mad at me. One second. I am really, this is just being Word being mad at me, I think. Where'd you put it in the,
Oh, just in the chat.
oh, I don't see it.
Oh, maybe it's not working for everybody.
I can see it.
Oh, maybe it's just mad at me. Okay, I got it back. I'm back. I'm back. I'm back, baby. Um, all right. So now, okay, so we have our area of foot process effacement. We have one lesion that is actually pretty uncommon, but this is a binucleate podocyte. Podocytes should not have multilobulated or multilobular nuclei. It should be a single nucleus. It's not a polymorphic nuclear cell. So the fact that we have two nuclei within a podocyte does again show us that there has been injury to the podocyte lineage. Do any of the pathologists, especially Sarah Lynn, know how binucleate podocytes can happen? Or Haley? You'd have to unmute yourself or you're going to put it in the chat and I have to see it.
Isn't it like that rarely they have the ability to undergo mitosis and sometimes they
going.
don't go well.
Okay. Yeah, you've said it in a vague way. So they can replicate their nuclei, so that's karyokinesis, but they are really bad at cytokinesis. So even though they can divide nuclei, they have the possibility of doing that. They're really bad at doing cell cytoplasmic division. So karyokinesis can happen in podocytes, but cytokinesis is the blockade. And that's how you occasionally get binucleate podocytes. Again, it does show that the podocyte lineage was damaged enough to try to undergo mitosis. But the literature suggests that the blockade for this process that podocytes can't replicate is because they can't divide their cytoplasm. I think I've seen a trinucleate podocyte once. And I have seen a few cases where most of the lesion is just binucleation of the podocytes. And like pretty much every glomerulus had it, and I had no idea what was happening, but I was like, this is just a gee whiz lesion, and I think it was a Tufts case. And I didn't know what to do with it, but I could say that, hey, I think something hit the podocytes a while ago, and now we have podocyte binucleation, and we had some sclerosis in that case as well. The other kind of information we had for this case is these little vacuoles that are hanging out in the GBM. Again, we see that lesion very commonly in a lot of different breeds, very discrete electron-lucent vacuoles in the GBM. It's usually on the subendothelial side. That's not pathognomonic by any means for glomerular lipid emboli, but the fact that we saw more electron-lucent material there is helpful. I think I'm just gonna, in the interest of time, I think I'm just gonna show you what it should look like, what the material should look like on EM, and I think the way I'm gonna do that is probably just pull out the paper. Or I guess I have it in the textbook as well. I think we talked about this in the textbook. And there were some questions on the chat. So I saw that there are comments about, does this only happen with hypothyroidism or diabetes? We have seen it in dogs, and this particular dog was not hypothyroid. Like I said, there have been old papers that have talked about this particular lipid material, and they actually also kind of conflate it with glomerular lipidosis, which is when you have the foamy macrophages. They kind of conflate the two and say that they're both almost the same thing. We think that you can see it in dogs that do not have those kinds of endocrine diseases. So I'm going to show you the figure that we have in this paper just because I'm being lazy. There's nothing like a bit of honesty, right? So this is our figure from our miniature schnauzer paper. Again, the paper is just lesions in miniature schnauzers. It just so happened that we had quite a few of these lesions, these lipid lesions. And so we were able to at least introduce the term. Here's my bad term. I don't like the term thromboembolus anymore. I'm just going to change it to embolus. But you can see again the clear space. It's quite discrete. It's in the exact same location in this gorgeously serially sectioned glomerulus. This is a section of the frozen tissue. So the frozen tissue is what it's never been processed. Like I mentioned, the processing is what dissolves the lipid. So the frozen tissue has gone through Michelle's and it has been washed and then it has been frozen into an OCT block and it has been sectioned that way. And so we can take that frozen tissue and section it and then take it to take it to the histolab instead of doing, I mean, we still do immunofluorescence on it, but on a different section, we put it on a slide and we stain it for a lipid based stain, or I guess maybe a lipid identifying stain. And this particular one was oil red O. You can also use Sudan black. And so that red material is a big blob of lipid. And so that particular glomerulus is not a serial section of the other four. It is a completely different glomerulus, but it was in the frozen section and it had a big blob in it. And you can tell that there's lipid material in that capillary. And then on EM, I know that's not super big. Let's see if I make it, maybe make it bigger. The material is just this kind of osmophilic, kind of slightly gray blob. And so if you're lucky and you get the section that actually has it in circulation, you can get a gorgeous image like this. So here is an endothelial cell that's quite squished. And then you have the capillary wall all around it. And I'm a little annoyed with myself that I didn't just bring up the actual image. Can I do this? Oh, hold on. Oh, that's as big as it goes. So you can see this endothelial cell is quite squished. We have a couple of really good pictures where it has a lipid droplet in circulation and you have like a squished red blood cell to the side. So you can see that the red blood cells aren't going to be very happy trying to circulate through these capillary loops either. The problem with, and I'm going to end here and let Nav talk about what they're going to do for treatment, but the one problem with imaging this on electron microscopy is that sometimes these droplets are so big, they take over multiple regions of the EM grid, and you can't really get a good picture because there's a grid bar going right through it. So you really have to be lucky in order like to look out and get a droplet in the field of view and not obscured by a grid bar, because sometimes these things are huge and it takes up almost the entire glomerulus because of how much lipid has kind of coalesced into this droplet. Okay, I'm going to stop and I'm going to let you talk about what you're going to do for treatment, Nav.
Yeah, so let me just pull the slides back up actually quickly. But I did find the blood work from the RDVM, so I just put that in here. So in May, we started the low-fat diet. Can you see the screen, or did I not share it yet? I don't think I shared
I'm not seeing a screen. I'm just seeing your face.
it. No one wants to see that. So let's do this. Okay, so in May, we started a low-fat diet, fish oil, and telmisartan for the proteinuria as well as for the hyperlipidemia. And then recheck the dog at the time of the biopsy. The triglycerides and the cholesterol both reduced pretty significantly with that intervention. We started fenofibrate at that visit as well, and then we started Plavix. I was talking with Eva Furrow a bit about fenofibrate versus using a statin in this dog instead. And her thought process was if the lesions looked more like glomerular, lipid emboli, using fenofibrate, would make more sense. But if there was, evidence of atherosclerosis, trying a statin. I also just don't have a ton of experience using statins in dogs, and so I was more comfortable starting fenofibrate. So we're rechecking the dog today, actually, shortly. And so we'll see kind of how we're doing with regards to managing the lipid as well as the proteinuria. But other than that, I also still question, how this relates to the dog's initial presentation, which was the seizure episode, which kind of prompted this whole visit, and whether or not that's related to this dog's hyperlipidemia in some way, or if it's just a separate issue, like this dog might have idiopathic epilepsy or some other seizure disorder as well. So that's kind of where we're at with things, and I'll keep everybody posted, of course.
I think Nav froze for me. I'm not sure if it froze for you guys. Oh, now he's
I might
back.
have just, I was
Now
just
he's
very
just
still.
sitting real still.
I'm a
So
statue.
has anybody else that have been clinicians managing this case or managing even a schnauzer with this type of lesion? What has anybody else tried any other medications? No.
I mean, I've always used fenofibrate or fibrates for hypertriglyceridemia, whereas statins I think make more sense for hypercholesterolemia. And because this dog's cholesterol was so profoundly elevated, that's why I was thinking of reaching for that. At least that's how I think of it and think of treatment. But I just don't have great experience with statin use in dogs, so I figured I would start with the fenofibrate just because we do see this lesion a lot in miniature schnauzers, and that's how we often will treat them as well.
But are the emboli triglycerides or cholesterol?
Sorry?
So the composition of the emboli, are they triglycerides or are they cholesterol?
Yeah, that's a great question. I do not know.
And I don't think we know. I mean, I think that this is something, like I said, we've seen this. It seems to happen a lot in schnauzers. But I mean, if we look back, I think we probably have 20 cases total out of 2,000. Maybe, yeah, 2025. Like these are not, this isn't frequent. This is a very uncommon lesion. But knowing the clinical background, when Nav said, hey, we're going to biopsy this really like dyslipidemic dog, and he was like, everything's kind of crazy on the lipid and cholesterol profile. Because I think you texted me in April or something. And, and I was like, yeah, and my mind was already, it's probably going to be that, or it's going to be the one that has more foam cells within the glomeruli. We need more cases of this so that we can figure out what's going on. But like Jessica said, Dr. Hocam said, in order to figure out what this material actually is, uh, technically we don't know how much protein is in there, probably not a lot because it does seem to be discretely lipid. So proteomics isn't really going to help us on the tissue. I think you have to have a different prep for lipidomics. So, these are the ones where we identify them and then we try to follow them. And then if we're lucky enough to get a second sample, then we might be able to prep a different type of analysis, but it's going to be hard for us to figure out. And we do have a question on the chat if you guys are going to do anything about the gallbladder. Okay, what are you doing?
Yeah, I mean, I'll probably recommend redoing an ultrasound at some point. It didn't really, there was not a ton of debris or anything in there that I was too worried about. So in terms of priorities, I don't know if the owner's financial kind of situation will allow for kind of, serial ultrasounds, but I wanted to focus on the lipids first.
Yeah,
And
and Dr. Shropshire has comments about that too. We've had a couple of dogs that have had more true atherosclerosis that have come through the biopsy service and have had basically atheroemboli all over the body. That's even rarer than this lesion. I know of two that are jumping to the top of my head. Again, they do have abnormal lipid profiles on blood work. But they truly have they have vascular damage like in the interlobular capillary, in in maybe even in arcuates, and they have systemic basically atherosclerosis. So it would be interesting to see what else is going on in other body areas to see if there's similar lipid globules accumulating elsewhere.
Rachel, Jenna,
Yep.
do you remember with the mucocele dogs, didn't they have similar histopath changes on the renal biopsies that Gukin had submitted?
They have a more higher frequency of focal segmental glomerulosclerosis. We know their podocytes are damaged, and they more often have the lipidosis with the foam cells.
Okay.
I that's more common in our experience. And we actually do have, and I at the time when I was still at OSU, I had a resident that was working on like kind of characterizing all of the histologic findings in dogs where a mucocele is discussed in the history. And again, FSGS is more likely in those dogs, but they can have a wide variety of things. Yeah, it needs to be published. I just haven't done it yet.
Yeah. And then the other thing I was just thinking about as far as when you were talking about lipidomics, and thinking about what might leak through the glomerular capillaries, did this dog have lipids noted in his urine sediment? Because I wonder if that's something that could be analyzed more for actual cholesterol versus triglycerides, if you could actually look at the lipids within the urine itself.
I will need to go back to his report.
Yeah, let me take a look. I can pull up the
But admittedly, we see lipids in a lot of urine.
Sure. Yeah, I know we see it a lot, but I'm just wondering, like, clearly some stuff's getting stuck in glomeruli, and then
Yeah.
it seems like it wouldn't be impossible for some to then make it through as well. I don't know, just to help differentiate what might be present, and maybe it means nothing, but
We did not actually comment on lipids on that case. Interesting.
they all got stuck.
Yeah.
This is an EPON block. This is quite tiny. This is like maybe what, 2 centimeters long? Maybe a centimeter long.
Centimeter and
It's
a
a
half.
different dog.
maybe? Yeah.
But this is kind of what they look like. And so when you label them, you have to do this like label around the EPON blocks. They're quite small. And then this little nubbin right down there is the tissue. So whenever the EM technician is trimming, they're trying to get a glomerulus within this tiny little piece. And we don't have a ruler for scale, but this is quite small. So that's what that looks like. For educational purposes.
yeah, no lipids in our urine either when we submit it to our labs.
Yeah, so if you're thinking about it from a research standpoint, the best way to characterize what this is to know what you're getting into when you're biopsying a dog, or maybe when you're deciding to biopsy a schnauzer, getting an extra core that you could do. And obviously, I'm saying the word lipidomics. I've never done it before. I just know it exists. So we would have to figure out what kind of prep you would need to make sure that the lipid doesn't degrade and you can analyze it. You would kind of have to know, like, hey, I'm suspecting this already, and then I'm going to collect a piece of tissue just so I can analyze what's in the glomeruli. So, interesting. Are there any other questions as we're getting kind of close to the time?
Let me
Mhm.
elaborate a little bit on my comment about the composition of the lipid emboli. Clearly, the dog's dyslipidosis is composed of both very high cholesterols and abnormally high triglycerides. And in the bloodstream where those measurements are made, they're all mixed together and suspended in the plasma and whatnot. But there is the possibility that when they get to vessels, that what happens to them differs depending upon their physical characteristics. And their triglycerides globule up in a way that I kind of think, but I don't know for sure, cholesterol doesn't. You talk about cholesterol clefts in tissue and where deposits of cholesterol look more like crystals or that kind of thing. And so I didn't expect anybody would know, but I wanted to stimulate a little thoughtfulness about what might be the difference in the composition of the lesion you see through the microscope and the biochemical abnormalities in the blood that you're trying to correct with the medication.
And I think that one last thing which I did want to mention is I've never seen this in a human. I mean, I've seen atheroemboli a lot. Not because it's so common, but because it's one of those things that when we see it, we always show it at rounds. So I've seen the atheroemboli a lot. Again, like George said, those are crystals. So they're the acicular clefts. The pathologists know what I'm talking about. You can see those in glomerular capillary lumens. It's one of those things that we always show at rounds when we're at the med school if we actually catch them. But I've never seen droplets like this or globules like this in a human. So again, just difference in species. Yeah, so it's kind of an interesting lesion. And you might suspect it based on blood work before you do the biopsy. And then it would be great for future projects to see if we could identify what the globules are made of. So, and Dr. Limprano sees it in leopards. You see the lipid emboli, correct?
Yes.
Yeah.
And it's been in like it. Yeah, they either have that single discrete globule or end up having those multiple. And it was confused for. They thought it was like fatty metaplasia. That's what one of the pathologists thought, that it wasn't actually in the capillaries, but that's why we did EM with you.
Yay. So stay tuned for that publication. Okay, I'm going to sign off. Oh wait, before I sign off, let me see. I mean, not like it super matters because I have to send out the invite anyway, but let's see about August. August looks like it's the 19th. And I think it'll be fine to make sure we have rounds on August 19th. Thanks, guys. Thank you now for presenting when I specifically forced you to do it. Thanks. Okay, bye. See you guys.